Welcome to the APAPP podcast. I'm Corinne Young, your host today, and with me is Dr. Melisa Wilson, a nurse practitioner in the field of pulmonary hypertension. Her extensive education, including multiple degrees from prestigious institutions like the University of Florida, Florida State, and Duke University, demonstrate her dedication to advancing her knowledge and skills. As the pulmonary hypertension program coordinator for the Advanced Lung Disease Program at Advent Health Orlando, Dr. Wilson plays a critical role in coordinating care for patients with complex pulmonary conditions. Her leadership as a Division Advanced Practice Provider, Director of Heart, Lung, and Vascular Specialties, and Chair of the Advanced Practice Council further highlight her leadership skills. Dr. Wilson's involvement in clinical trials and research as both principal and sub-investigator underscores her commitment to advancing the field of pulmonary hypertension. Her contributions to publications and presentations at medical conferences have likely had a significant impact on shaping current practices and guidelines in the management of pulmonary hypertension. Lastly, she serves as the curriculum director of education at the PAH. So she is the perfect person to have on our podcast today to discuss some new treatments in the field of pulmonary hypertension. So Dr. Melisa Wilson, thank you so much for joining us today.
And thank you, Corinne, for the opportunity to speak with you.
Absolutely. Not only is she so accomplished at all these things, I love to brag on her, but she's also the sweetest, most wonderful person who I like to force into being my bestie at times. So I'm so glad I was able to wrangle some time in with you today.
It's an honor. And honestly, it's not hard. You're easy to love.
All right. So let's start with Sotatercept, the drug that has been such an exciting new thing for us, a whole new class of therapy for pulmonary hypertension, pulmonary arterial hypertension patients, and something that we have all been waited with bated breath for it to come to market. It's finally here. So if you could help us a little bit understand this new class and briefly how it works.
Okay, so Sotatercept is not a vasodilator. Let's make that part clear. It doesn't work like any of the other PAH medications that are presently available for the management of this disease. It is a activin signaling inhibitor. It's designed to specifically target pathways involved with or that contribute to the abnormal growth and constriction or narrowing that occurs within the pulmonary vascular. By focusing on these mechanisms, it's able to help reduce pulmonary vascular resistance as well as increase the function of the heart overall. It's another way, I think, to maybe kind of describe it, because it's a little bit like in my mind, I was always trying to figure out like how exactly do I classify this med and understand what that means too. It is actually like a biologic. It is a fusion protein. It actually works in the extracellular domain of the human activin receptor type ACT-RII. How do you say that fancy in pharmacology? I don't know, but that's how I'm going to say it as a nurse practitioner. Combined with the FC domain within the human IgG1, excuse me. So it really works very differently. The other one's very easy to say, like, it works in vasodilations, it helps with proliferation or block proliferation and all. It's very different. And the way I like to describe it, that there's an imbalance within those patients with pulmonary hypertension between this receptor, as well as we know the BMP2 is also unbalanced or almost fractured is how I think of it. And this helps to bind, the medication binds to that and helps to restore that balance. So when you look at the different combinations that of these proteins in the human body and the patients with PAH together, when it binds that, it allows that balance, and then the body doesn't attack or treat it like it's a foreign body. And that's basically because of this IgG part of it. It's very complicated. Other than I really like to say, it kind of helps to restore the balance and binds to these receptors and behaves like a biologic.
So that's a really good point. How do you describe that to patients? Because I think they understand a vasodilator, or it dilates the blood vessels so there's more blood flow. So how are you going about describing it to patients?
Well, the first thing I tell the patients is it doesn't work like the other ones you have, and it works more on the cellular level versus in promoting or adding to or blocking something that already exists. That this now actually it creates a again that balance within the body versus it's adding. Like when you think of a, a PD5 or you think of a prostacyclin, these medications are adding something in that you are short. This doesn't do it that way. So it works differently. And because it works differently, we see a different response and honestly faster than we see it in some of the other medications and mechanisms.
Mhm.
But what I also explained to them is that we never study this medication by itself. So we've always studied it in complement to other PAH therapies. And therefore, I don't know if what's happening internally, all of those functions need to happen together in harmony in order for us to get the robust response that we see with the sotatercept.
I'm glad you brought that up because in this trial, it was add-on therapy,
Mhm.
to their background therapy. Usually, I think the majority of the patients were on triple therapy. Weren't they already double or triple therapy? Um,
Correct.
so in now that you've been using it, where do you find it the most handy? Are you using it as your fourth add-on? These patients who are still progressing despite being on triple therapy, your end stage patients. Are you adding it on earlier after dual therapy to be their triple? Where are you using it in your practice?
So I would say most commonly is the fourth agent is what a majority of our practice is doing. But I also am seeing it also as our third agent. And there's some patients that we're actually looking at it being their second agent, perhaps. And that second agent choice may come into considerations maybe about that patient or their socioeconomic status or their social determinants of health or their wishes and wants altogether. Really not, I love that my team has not been afraid to use the product in terms of really sick patients, only those who are in our Zenith trial are we really looking at those patients who are very sick, who are being in that, but it's not a rescue medication. So I think that's really important for people to understand that it's not something that we're going to give that injection, you're going to get this immediate remodeling, and their patient's going to, get out of the ICU. In those cases, you still need to be using the parental prostacyclins to help get those patients improved, stabilized. And now, when you're looking for discharge, it's an add on medication post discharge. It's not something that you're looking for in the acute setting. Um, you also, when we use it with those patients who are add-on therapy, it's going to be those people who they're doing pretty well. I'll be honest. Some of them maybe they even classify as low risk when you use the risk calculators. But when you look at their hemodynamics, it's not as we feel like there's more opportunity, not as optimal as we would like them to be. The patient's low risk and they're doing very well. So let's give them the opportunity to see if we can actually remodel that heart with this product and therefore hopefully adding years to their lives, right? So we're using it in those populations quite a bit. Those patients who are intermediate risk, definitely adding this on very early, very making that choice very early to say, hey, let's submit for this medication and the sotatercept at the same time too. Just really working to say like let's give them all we got. Unfortunately, because we have had participation in several of the clinical trials for sotatercept, we have uh, had the opportunity to see the progress of it prior to, or the progression of it prior to the patients actually getting it commercially. So that we feel has given us some additional validation as to where it could be placed in these patients.
Yeah, I think that was definitely a question, we all kind of had, and we're recording this as of like mid 2024, and I don't think, and correct me if I'm wrong, I don't know if anyone has come out and said, a stepwise approach where to add this yet, right? We're just kind of basing it off of the trial and how they were using it in those patients.
Predominantly off of the trial, the World Symposium for PH did occur earlier this month.
Oh, that's right.
So there are some guidelines that will be coming out soon, but due to the embargo, I'm not allowed to share. They made that very clear to us. We're not allowed to share, but some guidelines around that will be coming out. So yes, everything we're doing today is based off of what we know from the trial data. One of the things I think it's also nice to point out when we talk about where you place it is there's the concept in our minds as traditional PAH managers is you have patient may be on triple therapy, and that triple therapy, when the patient is not optimal, let's say that third prostacyclin, that agent, that third one being the prostacyclin, when they're not optimal, we're usually converting those patients to parental therapy. And we know that there's been patients sometimes that they just cannot. As much as we as a medical team know that this is what the patient needs, they cannot. And it could be for lots of reasons. It could be because maybe they are a IV drug user recently become clean, may not be someone that you would want to risk that. Maybe it's because they don't have vascular access. That's a very real thing. So IV may not be the right choice. They maybe have had a sub-Q pain, and now I'm worried about people with narcotic abuse. And I know I'm kind of referencing around that group, but that is a challenging group. And sometimes the other issues are that maybe it's an older patient who doesn't have the support to manage a parental therapy, or someone who has dexterity issues because of their connective tissue disease. And those patients who maybe they're able to do an oral prostacyclin or they're able to do an inhaled prostacyclin, but unable to do a parenteral prostacyclin, we're looking at using that sotatercept in this patient population as well too.
Yeah, that absolutely makes sense. Yeah, that sounds great. You'd mentioned a little earlier that, we're not gonna give them this injection and they're gonna be perfect. So this is an injectable therapy.
Mhm.
So far we have oral, we have inhaled, we have parenteral, we've got sub-Q, but this is our first injectable therapy, right?
Right.
How are patients accommodating to that?
So first, they always say, "Is it going to hurt like the other one?" That's what I hear often. Is it going to hurt like that? And is it all the time? Because again, understanding what the subcutaneous treprostinil is like, they're like, "Is it? How does it work?" So this is a once every 3 weeks injection, sub-Q injection. It's a very simple, short shot. Generally, doesn't even have any pain at the local level of where you're injecting it. So they are very savvy in asking those kinds of questions and very excited to hear that it's something that uh, they don't have to, let's say, carry around every day. That gives them a lot of excitement around it. So I have found even those on parental therapy have been excited and willing to do it because it's not management of an additional pump. The other nice thing I tell them about it is it's once every 3 weeks. So I have a young lady who's going on family vacation soon, and she's getting ready to she's interested in starting this medication. So I said, so you know what we can do? Let's plan your start around your vacation. So that way when you go on vacation, you don't need to bring any medications with you. And her daughter just lit up. They were like, "What? I don't have to take this with me?" I'm like, "No, you gotta take all the other pH meds. But yes, this you'll need to like you can plan it that you do it the week before you go, and now you don't have to worry about it for or even the same week you go. And then you don't have to worry about it for 3 more weeks again. So I have found patients to be very excited about that. Everyone's kind of wondering, well, what is it going to do? Should I feel anything? Am I going to feel anything? So I'm very transparent around the benefits, very transparent around the potential side effects that they can experience, and very clear in explaining what others have experienced. Which I'm like, most people don't have any major side effects associated with this. Um, Headache was reported in the trial. I have personally now, well, I'll describe what our clinic setup's like, and I can tell you how many patients I engage with uh, since um, since launch or since it's actually commercially available, and uh, most people don't have that headache side effect. I've had one person out of the now we're well over 20 patients who initiated um, Sotatercept who said, I had a headache, but I'm not sure if it's that or it's my other med because my other med always gave me one anyway. But headache really, though it's most commonly reported, really doesn't happen much. And then they asked me to like, well, why does it have a headache? And I'm like, that's the thing, it's not a vasodilator. So I really don't know why it creates a headache in some patients. I think my theory is perhaps it's because maybe it's making those other meds work more efficiently. So maybe you're getting an effect from that. Or maybe it's because we expect it to give us a headache because every other one did, right?
Mhm.
All the other meds are vasodilator and perhaps did. So we're learning as we go and learning from those who are actually on the product. and what their feedback is. They're not having major side effects. They're not um, feeling bad. They have no down days. But they also will describe early on, I don't feel different. They're like, I don't feel anything yet. I'm like, oh, give it a little time. And then you may see trends in other areas. Like you'll see trends, their BNPs legitimately go from thousands to hundreds to lower hundreds to single and double digits. I mean, so really seeing that trend there, you can see like, yeah, you may not feel different yet, but I'm seeing the things that clinically I like to see, and I look forward to when they do their walk test and their echoes and their repeat heart catheterizations to now also demonstrate to them that they're doing more. Then I've had others who literally after, they get ready for their second injection, they're like, is it in my head? But I feel better. So it's very interesting how one person responds versus another. But overall, it's been very well tolerated and been very positive.
Excellent. There is a very unique structure to how it's initiated and monitored. So, can you talk to us a little bit about that? I remember when we were reading about it, I was like, oh, because we are not a PH center, we manage a lot of PH patients, and I was thinking about the how this was going to impact my staff too, and because we have a PH navigator who monitors our patients and make sure all the things happen for us. And I was thinking about how this was going to impact her and the providers in our practice. So if you could talk to us a little bit about that.
Sure. So the medication is known, or side effect potentially is lowering the platelet count, right? So thrombocytopenia. And also it may increase the hemoglobin and the hematocrit. So the package insert does require or recommend, I should say, that you get a hemogram within 7 days of each injection for the first five. So our approach in our clinic is that I see all those patients. So instead of them getting the lab, us waiting for the lab, we actually have an appointment. So we set up when you start, you're scheduled for your lab day that we recommend you go get your labs done. And even though it says 7, I really prefer to keep it closer to the appointment. So 5 to 3 days is optimal to me. The same day, even better. Just makes me feel better. But that's because I'm also the researcher, right? So the researcher in me wants it to be as close to the date of the injection as possible for that evaluation prior to. Then they have a virtual visit with me, right? So utilizing our technology, virtual visit, ask about their weight, have they had any change in their weight, have they had any side effects, how do they feel, and really focus it around just is it safe for you to take your next dose. If the platelet count is less than 50,000, a patient is not able to proceed with the next injection. So we literally have an APP design clinic around that they do. So I see them for every 3 weeks for the first 5 injections. And then after that, I have been kind of still learning, right? With kind of as one of my leaders at work says, like we're flying the plane as we're building it. So learning what do we want to do next, considering things like cost, and what the recommendations are, uh, and even just hate to say it, right, beating up the vein every time you go to get labs, trying to figure out what is the perfect protocol around that. Recommending the patients still get it every 3 weeks until they get in for their regular standard of care appointment with visit with their provider, who could then make the decision if they would like them to change that to monthly or every month, or perhaps even go to quarterly. So right now, my recommendations, I'm having patients do it for the 5 visits. I have to see the results. I tell them they can continue to get their labs monthly, and the nurses will help me monitor those labs. They just won't have an appointment to go with it. But they also have pretty strict guardrails, right? Which is if your labs, if your platelet count is less than 100, you need to call me, period. I just want to see where it is. Why did it change? What do we need to do differently? Be proactive versus reactive. And I tell them that they continue patients see their labs on their portals often before we get them. And if your platelets are 50,000, again, do not take that injection. Call us right away for support. So I love the idea of having the navigator follow those patients and follow their labs. So the biggest hiccup I've had with my clinic has been labs not coming back in time, has been one challenge. And it's mostly been like if you go to a lab outside of the hospital system, that it may be prolonged. Or because it's a lab, you go in and you say, I need my labs ordered by Melisa Wilson today. And they're like, well, you have like 5 other labs here. Let's draw them all. And if it's something like a pro BNP in there, then certain labs won't release the lab. So now we have to kind of like play catch up. Um, and that visit is required in order for me to give the specialty pharmacy the okay for them to ship and to confirm the dosing. So that's been my biggest hiccup is that, or the one patient who you knew was going to be those challenges. Remember, I told you about some of those people who
Mhm.
maybe are not parental prostacyclin patients,
Mhm.
is chasing some of those patients down who they'll get on the call. They'll be like, oh, yeah, I didn't get my lab. I'm like, no lab, no appointment. No lab. I can't tell you what to do with your med. So let's hang up to now. Let's go over to the lab and let's get this rescheduled.
Mhm.
So that I have found to be more of the challenge. And I do feel like, though, having that conversation with them as the nurse practitioner around how they're doing, the importance of the lab, reinforcing that has helped those who have been kind of struggling all along, honestly, in their care with the adherence components. So that's how we're managing it in our clinic because I just worry about it kind of falling through the cracks.
Yeah. So if you see there an adherence issue prior to initiating this therapy, are you a little more hesitant to start this therapy?
Um, I think it's something we consider for sure, because you're not going anywhere to give yourself this injection, but we do know that this offers grace. So what we have done is for those higher risk patients, have like nursing call after they are done with their appointment with me, right? So that's why we have those first 5 visits with that monitoring, and then after that, having my nursing maybe call if we're having any issues from, especially pharmacy gives us feedback. If they didn't get the shipment or the patient didn't answer the call, that we can use our nursing to help support that. So we have some reservation, but I wouldn't call it like an absolute exclusion.
Okay. Any other stumbling blocks you've run into with either initiating or continuing therapy on patients?
Um, no, I mean honestly, because it's pretty easy to add on. So no, I really hadn't. Except for I'd say one of patient recently had always had normal platelets prior to, and he hasn't even started the med yet, but started to change. His platelet count started changing for some reason. Of course, he has PAH and he's on other therapies, but I noticed that his took a significant trend down. So I actually decided before he started, I said, nope, let's stop. Let's not start the medication. Let's send you to hematology and to your other team to find out your other team members to find out what's going on, care team members, because I would like to ensure that we know it's safe to start the medication and I'm not going to put you on something and potentially do harm. So I think it's really knowing your patients ahead of time,
Mm.
and feeling confident that you have their care team support to understand what's going on with him, to really help those stumbling blocks. So another potential stumbling block is we've had several deliveries of the medications where the patient forgot to pick it up from outside their door and it sat outside for 24 hours.
Oh,
This medication cannot be utilized. It has to be kept to appropriate temperature. It should be kept in the refrigerator. So anything that's been sitting out in the heat for 24 hours is immediate disposal. It cannot be used under any circumstance. So that I would say is a stumbling block that I really don't understand because they know better for the other medications. But maybe for some of those who have not been getting like parentals or like an inhaled product, they've been used to getting their oral medications. I think are now learning what that aspect of pH management is like. So we had just this past week 2 patients who did not pick it up from their front porch and had to get new shipments, and then we had to adjust their schedule accordingly.
do you notice any difference in outcomes or response to therapy if they have to delay dosing for whatever reason? I know like the knee jerk reaction to missing a dose of a pH drug, right, is always like, oh my gosh, you're going to have rebound pulmonary hypertension, bad things are going to happen. But because this is not a vasodilator, I'm assuming we're not seeing any of those issues of delaying an injection because of labs or delaying an injection because of shipment or those types of things?
So when I set them up for their original appointment, I do encourage that they do the injection on the same day of the week, every 3 weeks going forward, ultimately trying to create habit. However, if you did need to adjust a dose up to 3 days, is what is okay to be done for the window. Like I don't need to do anything different. You have 3 days that you could take it plus minus. I really recommend they don't do that though. I just don't because I feel like then you get in this habit of I did it every day and then I adjusted it this week. Next time I did another week. You don't even know if you're on week 2 or week 3 after a while. I feel like they may get confused with that. The nice thing is what they ship them is just the one time for the one use. So it's not like they have it in the refrigerator and could pull it out another time. Um, the medication's half life is actually 28 days. So if the patient doesn't get their shot on day 21, it's still in their system. Half life is 28. So you're really looking at 56 days that it's actually there in the body as well. And so if you had someone who was hospitalized and it was time for their 3-week injection and your facility did not have the ability to get that medication, it would be okay to delay it. I wouldn't delay it too long, but you are allowed to delay it up to 9 weeks if you actually read the package insert as well.
Awesome. Thank
Mhm.
you. All right. Other new things in pulmonary hypertension would be the combination therapy, Opsynvi, which is macitentan and tadalafil, right? In one pill. These two classes together, I call them the peanut butter and jelly of pH meds. I think a lot of us feel pretty comfortable with combining those two classes together. We usually initiate them together or stagger them together. And now they are an option in one pill. And
Mhm.
so the nice thing about this is that it reduces pill burden for patients. But, some of us are a little concerned about starting both therapies together. So I would love to hear your pro con debate of this combination therapy, starting it. Initial therapy for patients versus maybe transitioning them from two pills to the one.
So, in addition to what you said, the pill burden, it also saves cost, money. It actually, I have to give them credit. They priced it right. It is actually the same price as macitentan by itself. So that makes me very excited when I think about that cost saving for these patients. Because again, PAH is a lifelong illness. Um, as someone with a cardiology background, I'm very comfortable with combination pills. Upfront combination therapy. I feel I would be comfortable starting a patient on the lower dose initiation of the macitentan and then titrating them up to see how they do with the side effects of it. You know the side effects of the medications already. You know that both are vasodilators. You know that headache can occur. You know that um, one may cause edema and the other one may not. You understand that. So I also think patient selection matters just like it did before. So I think about if you have somewhat of a more elderly patient that you may be concerned may have some touch of diastolic dysfunction, then that patient may not be the one that you want to use this first on. You may want to use the loose pills to make the combination and then transition them to that combination perhaps. And in other patients, I think you go for it. You just go for it. You push through those side effects. You help support them. Just because it's a once a day or a combination pill shouldn't change the level of support that you provide as the healthcare team, right? So you're still going to support them. You're still going to tell them you may need to take some anti-inflammatory, or whether that be a Tylenol or an acetaminophen or an ibuprofen, whatever they are able to take ahead of taking this medication to help with that side effect. It's okay to do so. I found in my career that most of these meds, about 2 weeks, before the body really kind of adjusts, and that side effect tends to decrease. So I would treat it the same way. I do treat it the same way. Now, the cons, one thing people say is, well, when they miss a dose, you've missed two pathways, right? That's the biggest concern. When you miss it, you've missed two. And so then going back to the Proton, he said, well, if you missed one, what was the likelihood that you were missing either one of them in a day anyway? And how many times did you maybe plan to take maybe the tadalafil in the morning, the macitentan that night, and you took the macitentan? Um, you forgot to take the tadalafil, so you took them together anyhow. And this probably happens more often than we think. And one thing I tell people as well is it's a once a day medication. So even if you took it in the morning and you remembered at noon, it's still the same day. Even if you took it and it wasn't until midnight, it's still the same day. So it's okay to adjust that. Because you forgot it, to take it as soon as possible, and you should be fine. So I personally am very excited about it. I'm excited to see this combination pill that we already know works. The combination works, and to save patients time, energy, and effort. To me, all of this is about making these patients live as normal as possible. And then when I think about the opportunities of that in the setting of Sotatercept, I think how nice is that to be able to give yourself a once every 3 week injection and a once daily pill and have three different pathways being addressed with a simplified regimen. Isn't that what we all want? Best quality of life, simple, as easy as possible, and to be able to know you're living with PAH without feeling that burden.
Mhm. I would agree. I think up until just recently with these two therapies, I almost feel like the drug manufacturers have thought, how can we inconvenience the patient as much as possible? you know, 12 puffs 4 times a day, like all the different ways that we definitely inconvenience these poor patients who don't have much time left on this earth. And, we are definitely burdening them with therapies and side effects that it's so nice to actually see something easy for them. So I've been very excited about that too. To hear that you're excited makes me even more excited about it. So
I am, because we miss the boat often, like you say. I mean, one thing people tell me is I want to forget I have PAH. I want to live my life and forget I have this. I had a young lady recently who her daughter asked if she can go snorkeling with her, and she said, I'm thinking about what timing do I take my pump, what time, and she's on an inhaled product and orals, and she was like, you know, what timing would I take my pump therapy versus my oral therapy, and then do I need to take all those on the boat with me? And it was just, you know, so much to think about. And as a healthcare team, we understand that it's making me feel better inside, but I also want to help them feel better inside here. And so we really talk through all of that and what her options are and how to help her best manage that. But it was one of these bittersweet conversations because she's excited because she's going on vacation with her family, yet she's having to figure out what can she do and how does she manage all of these things. So if you tell me you can take that before you get on your expedition, go ahead, take it, go on your expedition. And you already got your injectable in and you can minimize how many times you take if you have options or, there's some products that are in study looking at like a once a day inhaled product or twice a day inhaled product. I think that's the direction we need to move towards, is helping these patients live their best life
absolutely.
without the burden of medications.
Correct. Yes. All right. So, new class of therapy, a new combination of therapy, new guidelines coming this year. So, I think that's a lot of exciting stuff coming for pulmonary hypertension. So, I appreciate you so much sharing that information with us and spending the morning with me. So, I can't thank you enough.
Well, if I have to find anyone to wake up and spend my morning with, Corinne, it's you.
Oh,
Thank you so much for having me. It really added some brightness to my day. I love talking about PAH and I love where we are going for a rare disease. The future truly is bright. And I'm glad to be here and to be part of that. At my 20-year journey, I never thought I would have the conversations I have with patients today and medicate around their life, their therapy, and how I can help them live a better life with PAH than what I even offered before. So thank you.
yeah, a lot of changes. All right. Well, thank you everyone for listening. Don't forget to claim your CME credit for this episode. The link for the CME is in the podcast description. You can find that link below or on our website. And please like, subscribe, and follow to help support APAPP. Until next time.